All right, future pediatric nurses, welcome. We're about to tackle one of the most critical skills you'll ever learn, how to respond when a child can't breathe. We're going to cover the absolute core concepts you need to know so you can act with confidence and, yep, save lives. So let's just dive right in.
So here's our game plan. First, we'll get into the unique anatomy of a kid's airway, the foundation for everything. Then we'll build your assessment toolkit. After that, a quick look at the usual suspects, then the major can't-miss emergencies, and we'll wrap it all up with your top nursing priorities. First things first, let's talk anatomy. You know, it's so important to understand why a child's airway is just fundamentally different from an adult's. This isn't just some fun fact for an exam. This knowledge is the bedrock of every single assessment and intervention you're going to make. I want you to really think about that for a second. 1. Single millimeter. This question right here, it gets to the very heart of why pediatric respiratory care is such a high-stakes, high-alert field. Let's find out why. And here is your answer. Look at that. A newborn's airway is only about 4 millimeters wide. I mean, that's roughly the diameter of a coffee stir. It's also shaped like a funnel, not a nice wide cylinder like in an adult. So when you get some inflammation, that one tiny millimeter of swelling can choke off over half the airway. It is literally a game of millimeters, with life or death consequences.
So let's break down what this actually means for you at the bedside. First, newborns have to breathe through their noses. That means a simple stuffy nose isn't just a minor thing. It can cause major distress. Next, their larynx is super flexible, which means it can easily spasm completely shut. Then you've got their high metabolic rate. They just burn through oxygen way faster and get tired much quicker when they're struggling. And finally, their cartilage is so soft that just letting their head flop forward, bad positioning, can completely cut off their air supply.
Okay, so now you get the why. Let's move on to the what. This next part is your hands-on toolkit for spotting trouble early and spotting it accurately.
Before you even lay a hand on that child, your eyes are your most powerful tool. You are looking for all those visible signs of increased work of breathing. Is their chest rising and falling evenly? Are their little nostrils flaring out with each breath? Are you seeing retractions, that classic sucking in of the skin between or below the ribs? Are they head bobbing? These are all flashing red lights telling you that child is working way too hard just to get air in.
Okay, next up, grab that stethoscope. What are you actually listening for? Well, crackles, they sound like popping, almost like Rice Krispies, and that usually points to fluid. Rhonchi are those low-pitched, snoring sounds that tell you there's thick gunk in there. Stridor is that terrifying, high-pitched crowing sound on inspiration that screams upper airway obstruction. You might even hear that one from the doorway. And of course, wheezing is that classic musical, whistling sound of a narrowed-down lower airway, like in asthma.
Now this right here is one of the most important distinctions you will ever make. On the left, in distress, the body's fighting. It's working hard, but it's still compensating. They're breathing fast, they're retracting, but they can still let out a good, strong cry. But on the right, in failure, the body is giving up. The two cardinal signs that they're tipping over the edge are a change in mental status, they get lethargic or super irritable, and a weak or even absent cry. That's a true emergency.
Okay. You know how to assess, so let's run through a few of the common bad guys you're going to see over and over again. Think of this as a quick-fire round to get these conditions locked in your brain.
Ear infections. Why are we talking about ears? Well, a child's Eustachian tube, the one that connects the middle ear to the back of the throat, is shorter and way more horizontal than an adult's. It's basically a superhighway for bacteria from a runny nose to set up shop in the ear. Your biggest job here, besides assessing, is drilling it into parents' heads why they absolutely must finish the entire course of antibiotics.
Next up, croup. If a parent ever says their kid's cough sounds like a seal barking, your brain needs to immediately go to croup. It's viral, it loves toddlers, and that super distinctive cough is almost always worse in the middle of the night. You'll probably hear that inspiratory stridor we just talked about too.
Tonsillectomies are super common, but your post-op care is anything but routine. Your number one, top-of-the-list priority is watching for a hemorrhage. And the most subtle and most important sign of a post-op bleed is continuous swallowing. They are literally swallowing the blood that's trickling down their throat. That is your cue to act immediately. And please remind parents, no red popsicles. And while a little bit of old dark brown blood is okay, any bright red blood is an emergency.
All right, let's shift gears. The conditions we're about to talk about are the ones that require instant recognition and perfect action. These are the red alerts.
This is epiglottitis. It's a nasty bacterial infection that makes the epiglottis swell up, fast, and it can slam the airways shut. Just remember the 4 Ds. Drooling, because they literally can't swallow their own saliva. Dysphagia, difficulty swallowing. Dysphonia, that muffled, hot potato voice. And distress. You'll often see them in that classic tripod position, just struggling for every breath.
Okay, listen very closely. This is the single most important safety rule in this entire explainer. If you even think it might be epiglottitis, nothing goes in that mouth. No thermometer, no throat culture, and absolutely, positively, no tongue depressor. Trying to look in there could trigger a total laryngospasm and close their airway for good. Your only job is to keep them calm, get some oxygen near their face, and get them to an operating room. Do not make them cry.
And this one is a congenital emergency. Tracheoesophageal fistula, or TEF. It's an abnormal connection between the windpipe and the esophagus. The textbook presentation is the 3 Cs, coughing and choking during a feeding, which is then followed by cyanosis, turning blue. The milk is going straight into their lungs. This is a surgical emergency, period.
Whew, okay, we have covered a ton of ground, so let's bring it all home and focus on your core priorities. When the pressure is on, what are the absolute must-dos?
Here it is, boiled down to 4 simple steps. 1. Know the anatomical differences. That tiny little airway is always your #1 concern. 2. Use your eyes and your ears to assess fast and assess right. 3. Recognize those red flag conditions like epiglottitis and TEF in a heartbeat. And 4, empower parents and caregivers. Give them clear, simple education so they can be your partners in care.
And that brings us to our final and really the most important question. You walk into a room. You see the retractions, you see the nasal flaring, you hear the stridor. What is your very first action? What do you do in those first 30 seconds? Answering that question with confidence. That's the whole point. It's about turning all this knowledge into immediate, life-saving action. And that, right there, is the heart of pediatric nursing.